which are the innovations and implications. The participants will speak about the core, what is at the core of the transformation, and about the long and short-term consequences for patients, for doctors, and also for payers and companies present on that market. The session speakers will also talk about what is important for those transformation, for those changes to be long-lasting, to remain in Poland, and what are challenges associated with ignoring the challenges that the digital transformation has brought. I love this mischievous thought that the e-forum is taking place on the internet. However, it's not enough to emphasize that we are longing to return to the so-called business as usual. So the next speakers, Charles Alesi, Chief Clinical Officer of IHIMSS, Charles Palizou, the Chair of IHE Services Europe, and Ofir Maurer, Director, Israeli Minister of Health. Commentators and panelists will be also Jarosław Fedorowski, the chairman of the Polish Council, or rather Hospital Federation, Łukasz Jankowski, president of the district health chamber in Warsaw, Maria Libura, president of the Association for Health with for Prader-Willi symptom patients, and Krzysztof Grojecki, vice president of ASACO Poland. So, Krzysztof, what are you going to ask about the panelists? We ask three main questions to our panel members. One, what is the core of the change? We didn't ask about symptoms, but what is this change about? We also ask them what will the results of the change be, because when the Copernicus put forward his revolutionary proposals, nobody spoke about the Earth satellites. Yesterday we had the launch of the private space vehicle which reached an orbit. So the third question that we asked was what to do in order to make those changes lasting ones. So how to make them actually a permanent feature of the healthcare system. I will ask the same question to the panel members, what this will mean for the key players on the Polish health service market. The first presentation, Charles Alesi, please, the floor is yours.
Thank you very much for inviting me to this forum. I'm absolutely delighted to be here. My only sadness is that I am not here with you as I was last time I spoke to you, which is approximately a year ago in Sopot. I still remember the joy of being there. And I'm looking forward to actually meeting you in person, because that clearly is the only way we're going to manage our interaction in the future. Digital is all very well, but you really miss people. A lot of what I'm going to talk about today is exactly that, how we can use digital to meet people better. So let's think in terms of exactly how we're fitting to fit this new world of health and care, and how best we can manage this new world of COVID. For those of you who don't know HIMSS is an organization which actually is a not-for-profit. It's a global not-for-profit, and its vision, and it's really all that one needs to know, is to realize the full health potential of every human everywhere. So in essence, what I'm doing today is part of our mission, because the advances you're making in Poland, and thanks for those two presentations from the minister and from the head of the Senate clearly were pushing in that direction. Could I have the next slide, please? But I think we need to figure out exactly where we are at the moment, because if we look at whether the systems we had were sustainable before COVID, we find that perhaps they wasn't. We have aging populations, particularly in Europe. With age comes multimorbidity. With multimorbidity comes increased complexity. With increased complexity, of course, comes burnout. And also, our workforce is aging at the same rate our populations are. And with multimorbidity as well comes overtrading, because, of course, we manage non-communicable disease on a life course. And the management of those is really quite complex. And we are moving towards a world where people were talking about changing the metrics, in other words, the drivers that drove health and care, from activity-based metrics to ones which actually encompass population health. And this is all before COVID, because COVID has changed an awful lot of things. Could I have the next slide, please? COVID really accelerated all the movements towards digital at a speed which was really quite extraordinary. It's really sobering to realize that face-to-face consultations in Europe reduced by about 65% if you look at every country. That's an enormous change. In other words, an enormous change around moving to digital modalities. And of course, the first thing we learned in the first wave was that, health and care systems couldn't look in two places at the same time. Yes, they did manage, some better than others, to manage the first wave of COVID. But what happened in most, if not all, European countries is the effect of that was that they took their eye off the care of the non-communicable diseases. Strokes, heart attacks, type 2 diabetes, dementia, all these conditions don't stop because COVID comes. And if we look at the excess deaths in Europe, it is really quite sobering, because what we find is the rate of excess deaths is really significant. In some places, approximating the rate of deaths associated with COVID. So this is really quite a big issue. And this has really pushed digital transformation forward fast, to a degree that we stopped thinking about risk as we used to. Before, we used to talk about the need to transform, but every time I've heard that sentence and that comment so many times in different parts of the world, whereby all we talked about was the fact that it was impossible to even consider moving ahead to a situation where we replace digital modalities. And that is mainly because, of course, the risk associated with that change. Suddenly the risk wasn't important because we had no choice but to move ahead. Could I have the next slide, please? So if we look in terms of what the new world's going to look like after COVID, these changes are embedded now. The new world is not going to be like the old world. And with digital transformation comes transparency, because you can count, you can see what's actually happening. So the management of unwarranted variation is going to become more important. Workforce and burnout of all the clinical groups will continue. Of course, it's a really big issue, and it's something we need to continue to consider. And we also need perhaps to think in terms of exactly what we mean around the management of non-communicable diseases. And I'll mention a little bit about the age of precision, because I think it's really important. It's a brand new world which is opening up in front of us. But all this depends on us being able to actually manage the changes, because, of course, these changes don't come naturally. We're changing the clinical flows. We're changing the workforce quite dramatically. The change management is a really big challenge for us all, of the workforce as well as of the population, of course. And there are issues still around the secondary use of data, the nature of consent. There are big areas which we need to concentrate on, and I'll come back to those again. Could I have the next slide, please? I'm going to go into some little deeper dives just to show how things have changed. Next slide, please. And I'm going to look at first how the consultation has changed. This is a paper which came out 5 years ago from Richard Milani in the United States. And it looks at the traditional healthcare model on the left, with the physician being at the center, referring people as appropriate, like my father did, who was a physician like I am, to the new healthcare now, where we're looking at analytics assisting the patient make the changes themselves, an activated physician, where we're looking at the non-health determinants, whereby all that social support is important. So it really is fundamentally different, the new world we're looking at. Could I have the next slide, please? But the biggest change, of course, is in the precise way in which we're managing care. And we've all heard of precision medicine. Could I have the next slide, please? Precision medicine, of course, is really very different to the medicine we're used to in the 20th century. The medicine of the 20th century was evidence-based care, where populations were dealt with in the same way. The new world is precision medicine, means it's evidence-based care, but for me, only for me, it is really fractionated. And if we look at the number of treatment pathways, and of course this all contributes to burnout, we are looking at significantly greater numbers of pathways. And together this, we're adding in all the genetic, epigenetic, and behavioral data. Really, and we see this in molecular diagnosis and the treatment of cancers now more and more. So these are all really very big changes. Could I have the next slide, please? But the biggest change, and I think the new frontier, is precision health. Because we now understand that in the management of non-communicable disease, you need to look at a life course in terms of treatment. In other words, you need to start treating people before they develop symptoms. We are talking about engaging with populations to manage their risks down before they're ill. I do not have cardiovascular disease, as far as I know. I don't have any symptoms, but that doesn't mean I shouldn't start thinking in terms of managing my risk factors down, increasing my level of exercise, managing my weight, not smoking, managing my alcohol intake, ensuring I have blood pressure which is controlled. All these things are part of these precision health approaches. And there are systems now which are developing these things at scale for populations. This really is the new frontier. Can I have the next slide, please? And what does this translate into? This really translates into a new, much more engaged patient and citizen who takes more control over their lives. And this is a life course, as I said, and this is important. It also means that care is received in a whole variety of different places, not necessarily only in a doctor's surgery. And of course, we need to keep on thinking of the importance of burnout and workforce and change management, because without that, we're not going to deliver what we need to. So what are the implications of this in terms of technology? Could I have the next slide? Because there are implications for all of them. Telehealth was really the start of this journey. Nosocomial infection forced us to move into a telehealth situation for consultations and contact with patients very, very rapidly. But this new world means interoperability is something we have to understand and we have to live with, and we have to implement quickly, because if we don't, we can't deliver that population health dimension we're talking about. And all those wonderful new data points mean we can use artificial intelligence to get the insights we need to modify our care. And the analytics means we can know exactly where we're succeeding and where we're not. We really are in a new world. Can I move to the next slide, please? So what do we need to do now? And we're only talking about solutions because that's important. Well, we really need to build on this revolution in telehealth to introduce the whole gamut of digital transformation. And we really need to keep the thought of burnout and change management very high on our minds. In HIMSS, we are developing and have developed some digital programs specifically to assist health and care workers come to terms with this new digital world. Because, you know, a consultation over the internet is not simply a translocation of a face-to-face meeting. As a physician, I spend a lot of my time normally not only listening to what I'm being told, but looking at the person, looking at their hands, looking at their feet, looking at how anxious they are, looking at what they're not telling me as well as telling me. All these non-verbal signs are much more difficult to elicit using video rather than face-to-face. And really what we have tried to develop is a whole new training program specifically to assist physicians in coming to terms with this new world. And by physicians or nurses or anybody else, I don't mean the enthusiasts, I mean the mainstream physicians, the mainstream nurse. It's also important we need to start to move to transition to that new world of population health from activity-based systems. We can't continue with the activity-based systems forever. As we grow older, we clearly develop more conditions and more diseases. And of course, as a physician, I can find something wrong with everybody who's listening to me today. And if I don't find enough, I'll look harder and I'll find more of them. And as I find more of them, I'll treat more of them. And I'm not saying I'll do that unnecessarily, but clearly we can't manage to continue in an aging society and a more technologically advanced society without also embarking on a world which actually manages this new world of health and care within a population health type dimension. I want to finish with a single thought, and I want to give this a little bit of time because I really want you to understand it. And it's really the limiting factor and the most important factor and the most difficult factor to manage. It's trust. Could I have the last slide, please? The whole basis of what we do with people, the whole basis of the care we develop, the care we've developed, the technology we've developed, the insights we can develop using artificial intelligence, everything we're doing is based upon the citizen, upon the individual, allowing us access to their data. Now, it's always their data, it's never our data. We may have custody of their data, but basically we need to ensure that people trust us with their data. They trust us to safeguard their data. Cybersecurity is really important, especially now with the explosion of digital transformation. There's many more chances things will go wrong. Really important that people trust us. They trust what we're doing with secondary use of that data. In other words, GDPR is very clear around secondary use. We need to start to have these discussions with our population. We need our population to understand what we're trying to do with the data that they are allowing us graciously to use to assist them. We need to assure them we are not misusing that data. We're not giving it to governments, perhaps unnecessarily or in an improper way. We are doing this with consent. So I think this is really, really essential that we have this dialogue. Because as we know, trust takes years to build, seconds to break, and sadly, forever to repair once it's broken. Thank you.
Dziękujemy, Charles, za te...
Well, thank you, Charles, for your introduction to our discussion and highlighting key issues, especially those related to the environment to which we are introducing health technologies. These are both healthcare professionals, their approach, their capabilities, and everything that is related to the environment, and especially trust, which is the key from the patient's perspective. Okay, so coming next is Charles Pruszko, and he will offer his perspective on this breakthrough moment from the perspective of IHE.
Yes, thank you very much, Artur. Very happy to be here and to join your virtual forum. And thank you for being so prompt to organize it and make it a success. It's my pleasure to be here. So I'm clicking on the screen. Oh, yes, it works. So I am here representing IHE Services. The integrating the healthcare enterprise has been on the forefront of accelerating interoperability and making it a simpler and a more effective and a more focused effort. And we are proud to have succeeded in many countries. We have helped Poland along the way a couple of years ago. And understanding the new situation resulted from the SARS-CoV-2 is indeed a very, very interesting and important topic. So we would like to look at what has happened on e-health in the February to May timeframe, then distill some takeaways and see what has been achieved on the strategic point in terms of strengths and weaknesses of what has been achieved. And we will conclude by looking at other elements that may come around and help us in moving forward in the near future. So, what has happened on the deployment of systems? It is critical to see how what is in place has been extremely useful for several countries, several regions. We have seen the effectiveness of those that had deployed, the sharing of laboratory reports, laboratory results among the general practitioner and the hospital, and how their ability to report and share COVID-related tests in a very efficient way was actually there and available. And that is an encouraging point and a lesson we need to remember, because using what is there is actually the easiest, the simplest entry point, obviously. Many countries have some hospital reporting to public health in terms of their admission, discharge, diagnosis, severity, and we've seen how critical data is, how challenging it has been actually to collect accurate data. We've seen countries coming back several weeks later and having to correct their data. We've seen countries realizing that the frequency of reporting, the way to collect the information, very often on a manual way, on a web browser, on a central server, that required re-entry and recapture of data from the hospital system to the public health system, how this was tedious and was putting additional stress on the workforce, how the frequency of those reports was not adequate. Many countries had monthly report, and they had to move to weekly and even daily report in terms of hospital admission of COVID patients. It was also important to track the vital reporting in terms of death and death diagnosis, and that is a process that has been in place for several years in most countries, and in the end it proved a useful indicator in terms of judging the epidemic and its impact. We keep on sometimes not using sufficiently that data, which is often the case, for example, in the present situation. We've been focusing on the test result and not necessarily understanding very well the death impact and comparing this second epidemic with the first one. However, the biggest lesson, in my opinion, have been learned with new services that have been introduced. I'm currently working with a country that has introduced a COVID test report system, and discovered that it was a pretty significant endeavor to introduce those systems to make sure The laboratory knew how to use them and to properly use them. The physicians had access to it. The public health folks had access to it. And these systems were actually much harder to put in place than anybody would thought. And despite the motivation and the attention that was placed. Definitely, Charles Alesi was very clear on this, is that remote physician consultation with some form of interactive video and sometimes even email, which was hardly used before, except in some special follow-up situation, was rather widely generated. And we've seen some very interesting finding in this area, as well as some interesting challenges. The main one being how much adaptation was needed on the physician EMR system to integrate those remote consultation with their typical workflow that they had well established when the patient was physically present in their waiting room and in their office. Finally, pretty mixed result around the contact tracing. I have an R here, which is not you. And we're not going to discuss this, but again, we are discovering that deploying large-scale application that rely on interoperability and the management of health data and privacy issues is not something that you improvise. And we've seen a lot of improvisation in that context. So introducing new system, new interoperability when the health system is under stress is a major challenge and actually proved to be quite difficult and in a number of cases quite ineffective. However, we have seen positive and negative in a sense that some health projects have been postponed because the stress on the systems and the attention was no longer placed at deploying new application, new collaborative care processes. We've seen those slow down, but it is pretty likely simply a postponement and a refocusing of resources during the crisis. However, we are continuing as those systems are being deployed to discover that they are bottlenecks in deploying e-health, and especially even with systems that were fairly new, and we have some experience in the UK and in Holland that were in the pilot stages, moving from the pilot to a fully operational situation proved to be quite difficult. Finally, on the future, we are seeing how interoperability at scale is rarely introduced in an expedited way. So this is a humbling experience. Interoperability is something that you plan. You need to understand what you do. You need to engage all of the impacted parties and stakeholders. You need to have good specification, good testing, and this is not something that was possible during the time of crisis, especially with the new system being deployed, and typically their interoperability has been found quite weak, and if not, to have to be completely redone. We also have learned how manual approaches that are okay in a normal time are suddenly becoming a major burden. So that needs a redesign. But we have experience, we have gained experience. But my overriding conclusion is if you had a weak interoperability or lack of interoperability of governance for managing interoperability and its deployment, you really suffered. And we've seen the country that had a governance on interoperability that were able to stretch and accelerate things. So let's remember that unless it is governed, interoperability does not appear magically. And this requires a process. This requires skilled people that understand the use cases, that can define them, that can help the country prioritize and deploy and specify and test and finally realize what is the promise of interoperability. Let me stop a minute on the policy and practice side. Yes, there has been disruption. Innovative disruption is a positive thing. However, I would like to look back, and the feedback that I got from several of my friends who went through, for example, remote consultation, is to say, I'm not sure my doctor is going to continue. I'm not sure unless it is during a time of restraint, such as COVID, that I accept it, but would I accept it on an ongoing basis? I think we have some challenges here, and we should not necessarily rest on an apparent success achieved under pressure. Things may recess, and we need to understand and manage that situation. And we also have seen that privacy, and I fully agree with Charles, how much privacy is a challenge, remains a challenge, and any reduction or attack on privacy, or what may appear as an attack on privacy associated to health data, is a case of death for e-health. So although certain things have been done, I would say to the limit of the acceptable into a number of countries, we need to realize that the scrutiny at that level will remain high, and the patients are not going to go for quick and expedient approaches on that front. Which leads me to say, yes, we can see a brighter future for e-health. We can forecast an acceleration of projects and a demonstration that population health and interoperability and more collaborative care and sharing of health data in the effective treatment of patients will happen undoubtedly. However, there are clouds on the horizon, and we hit on some of those. First, we need to realize that the resourcing of the deployment of connected system need to be something considered on the longer term. And it is not something you deal with on a commando approach. This is something that needs to be sustained. We also have a number of topics that are brewing in the background. More sensitiveness to the citizen about conflict of interest, using COVID to get me to swallow other things or to do things that I don't necessarily want to do, and seeing in the health system the fact that there are conflict of interest, and these need to be managed, and taking advantage of the COVID situation is something that we are increasingly seeing the patient react. My take is that we have to be careful as e-health to not fall in that trap. It is something we need to be careful about and not be associated with a undue usage of the COVID crisis to impose, to force e-health solution. No, they need to be still defended on their merit. Yes, we have benefited from the COVID situation, but let's be very humble and prudent on how we use this to convince moving forward. Furthermore, we've seen the government under rather heavy stress, at time being challenged in their actions and plans and credibility. Some citizens have grown to be suspicious of some government action taken during the COVID crisis. So thing that the government is going to impose e-health is also something that was a challenge before. And my take is that it will likely remain the same challenge because we have that sensitivity that we need to account for. Also, we've had a tension built between politician and administration and the medical practice. Medical practice has been by tradition fairly independent, and its independency was seen as a quality and a guarantee for the citizen, and some more, I would say, directive attitude and driving and forcing certain medical practice during the COVID was a mixed bag. Some necessary things had to be done, but also some things that could and are challenged were also done. So I'm seeing all of this and saying, let's make sure that as e-health promoter, we are cautious and do not fall into those, what I would call traps. So let's be attentive and let's keep having a long-term perspective on e-health. But definitely, and this is going to be my last slides, there is a need to refocus investments. Public health has been a rather poor parent in the e-health strategy. It is true that, and we've seen countries that had, for example, statistical reporting. They had 10% of their hospitals that were reporting at the national level. And this proved very efficient for the past 20 years. However, in this case, the resources had to be managed on a much more focused area. The COVID has an interesting habit of being very active in certain area and almost absent in other area for reasons we don't understand. Therefore, having a complete reporting back to public health on patient admission, discharge, diagnosis, and laboratory result has proven a gap for the countries that had, I would say, a partial or statistical reporting that used to work in the past. So we need input from the entire delivery system. We need to remember also that building solutions for public health independently from e-health and care providing in a connected way and a more efficient way is a waste of resources and will not work. And we've proven that for the past 20 years. Public health and e-health have to ride together. They are two sides of the same coin. And this is why we need to now think in a more effective way how to deal with problems of interoperability and make sure we cover both the care delivery side and the public health side in each one of our use cases. So there are some interesting news also in the fact that the lessons on managing and planning interoperability. Who is the body who is governing interoperability in your country? That's a question that I believe each country, each ministry should ask itself and say, do I have all of the stakeholders on board? Is the process working? Am I actually working from roadmaps to use case, to specification, to testing, to deployment? And I have a pipeline of effort. Is this an organized process in my country? If it is not, then things and the next crisis will only make things worse. So when we are in the crisis, we are not going to upgrade the system. We're not going to do major progress on interoperability. We need to do it after the crisis and make sure that we have a solid governance in place for that. However, we have some interesting perspective in front of us, which is the many large health infrastructure that are now in place and connecting point of care in more than 10 countries are largely based on IG profile. This is proven quite effective and working. We are now reaching probably 300 or 400 million patient records that are connected this way. So we know how to be successful, and we can leverage this. We also have some new collaboration being put in place. IHE, HL7, and HIMSS have joined forces in the Global Consortium for e-health Interoperability because of the realization that we need a more cohesive approach going from the planning of future standards, standard extension, profiling, testing, deployment. All of this needs to be made a much more integrated process so that the entities that are supporting the governance at the country level can have a better contact and a better way to get their questions and their need answers. And last but not least, we are seeing a turning point right in front of us for HL7 and the fast health interoperability resource standard, the HL7 FHIR, which has now matured, and we are seeing profile adoptions beginning. We are on the verge of transitioning this to be a wider scale adoption. That was not the case before. It was hoped, it was worked for, and probably the next release of FHIR, which is planned for the upcoming year, will bring that stability that we all need to deploy at scale, FHIR along with other standards, because as we know, there is no magic standard that will do everything in healthcare. So I would say, and I conclude with this, make sure you bring your support to the IHE HL7 and HIMSS collaboration and join and contribute to the Global Consortium on e-health Interoperability. I think this is a new opportunity to move us faster. Thank you.
Dziękujemy.
Thank you, Charles, for this very broad outlook, ranging from involving users and user cases all the way to the global standardization. The European standardization, I think we saw many topics, especially as regards the health strategy. We have seen many European examples, and we are going to see and hear a presentation from almost Israel. It's almost Europe, namely from Israel, from our cultural circle. We asked this year the representative of the Ministry of Health of Israel to say how much COVID influenced their strategies and how speedily they were in responding. Because for such things as pandemics, we need to respond very quickly, and on that speed hinges success or failure. So from that perspective, we should also consider the changes in the way how we operate, from our reluctance to accept risk for certain solutions up to implementing what is readily available, accepting at the same time that we are going to step up in a moment. So we need an agile approach to implementation of technologies and organizations in the health sector. And I believe this is the change that we see in other countries. That trajectory I spoke of before draws power from using other resources. In other words, it uses different sort of fuel to speed up the growth. Artur, Maya, the floor is yours.
Thank you for inviting me to the conference. It was actually a very interesting two keynote speakers, and of course the opening one. So I'm hoping it would allow some interesting point of view, different ones, because as we saw, the HIMSS presentation was very broad and worldwide looking. The interoperability was a very specific topic, and now we're going to try, and I'm going to try and take you on a journey, a very short journey of 15 minutes regarding the Israeli case study, trying to look at our digital health organizational usage and COVID-19, of course, And the title that I chose was "Never Let a Good Crisis Go to Waste," because that's the time that we're living in. I didn't introduce myself. My name is Artur Pruszko. I'm the head of policy and regulation within the Digital Health Department for the Israeli Ministry of Health. And as I mentioned, we're gonna look at three main stages of Israeli experience. The first one is going to emphasize on what happened before, because digital health was not started a month ago, a year ago, even 5 years ago. It had a very big foundation that we were building upon, and we're going to talk about it later on. A few moments and talking about what we did during COVID, and of course, once we hopefully tackle the entire thing, how we're going to cope and advise with the new normal situation. So let's start off with the normal, and I think that was already mentioned that a lot of challenges are happening. A lot of countries are facing the same challenges in regards to rapid population aging, to chronic diseases, to medication that are becoming much more expensive, to the public expectation that are becoming much more increased. And that it's not something that anyone on the conference or anyone in different countries should be aware of, because it really is a shared challenges that we are all facing. However, with a certain point of view, those challenges can also be looked at as opportunities. And that's what we were trying to do in Israel, again, before COVID happened. And we utilized our different unique opportunities that we had. First of all, standing on the shoulders of giants, we utilized over 20, almost 25 years of digital information that was stored regarding every single use within the healthcare system. So we've got a very, we're going to talk about it in a few seconds, but our healthcare system is not very big. The country is not very big. It's only 9 million people. But we only have 4 HMOs, 4 covering HMOs. We've got roughly 30 hospitals throughout the country. So we had an organizational system that enable us to utilize every single piece of data that we're using. And as I mentioned, a centralized management and regulator, which is the Ministry of Health, with a universal coverage by our HMOs. In addition to that, we had the opportunity to have a startup nation mentality, meaning that we had a lot of industry, high-tech, technology, R&D within the system that enable us to take the technology, the ecosystem, the atmosphere, and to insert it within the healthcare organization and to utilize it towards digital health. The last point I'm going to mention it at the end, but we again didn't start from the middle. We launched a new program regarding how to take digital health one step further. I'm going to talk about it in a few seconds. So taking all of those into account, the challenges, opportunity, and our unique perspective, we formalized 2015 a digital health strategy that was supposed to be updated this year, but of course, with everything happening, it's gonna be a bit postponed and obviously change because a lot of the perceptions are changing as well. But the digital health strategy mainly talked about a system transformation and a clinical one, taking the human-centered care and to create a sustainable healthcare system with every single point of contact utilizing the data, whether it's research, whether it's care, whether it's administrative abilities, and so on. And this was done with new care delivery models, new collaborations that were formed, and created new professions and skills, sometimes removing others, but mainly creating new ones. And on the other side, to create a new personalized, predictive, preventive, and proactive medicine, not to replace the system that at hand, but to enhance it and to allow it to be much better than it used to be. This was done with 3 main pillars: policy initiatives and regulation, of course, incentivizing system, industry, academic alike, and building of infrastructure throughout the way. Now, one example that I can give is, as I mentioned before, our national program for digital health as a growth engine. 2018 was our strategy, 2015 was our strategy, 2018 was our national plan, a 5-year plan. We're at year 3 out of 5, almost $1 billion shekel, which is roughly 250 million euros, that were designed to be to help our system, to create it as one of the world leaders, to promote new clinical and academic research, and to allow the digital health industry to be a growth engine for the system, but also for the country. And this led, again, to what we are seeing now. Over 500 different companies, innovative health companies, launched and operational within Israel. Over 25 years of health data. This is in use for primary and secondary usage of issues, with over 100 investors, 30 multinational, and almost all organizations with its own innovative platforms, whether it's research or an innovation system. And that led us to COVID. And as I mentioned before, the challenges were all across the board. Everyone was facing the same thing. And once again, with COVID happening at the same time, nobody really knew what it is. Uncertainty was a bundle, and you had to find a way to cope with that mechanism, to understand it, to fully utilize, to change the way of thinking. And that's what we needed to do. We had to create a new paradigm shift with regards to COVID, how to incorporate new models of care, how to utilize all data available, to integrate innovative technologies into care to help the system, to help mitigate and combat COVID. So I'm not going to elaborate on everything on this list because we don't have a lot of time. But I would say that our approach was a very broad one, a very holistic approach on regard how to utilize digital health within the system regarding COVID. Once again, I'm not going to talk about every aspect on the list. I am going to mention 4 very briefly, just to give you a sense of what we did. So the first thing that we understood is that the data is important. Of course, the data that is stored within the system, but also new data that was needed to be created, to be shared, to be analyzed, and then to enable, whether it's in the system and the organization themselves, but also for decision making and sometimes for the public. This is a dashboard that was allowing us to relay data to the public in various issues, with trends that are happening in the at the countries, in the hospital capacity, in tests, and so on. So we had to understand how we can utilize our own organizational use with our HIE, with our understanding and our connection with the hospital, and not only health organization, but also local government and other NGOs and a lot of other issues to gather the information and to utilize it in a better way. The second thing is R&D, understanding that the current situation was not enough, and we had to figure out a way to innovate even more than what we had to this point, because we had a lot of things in place, and I'm going to talk about it in a few seconds. But we managed to find ways to incentivize the industry with a unique call for proposal, over 400 proposals that were made, and with $15 million in direct funding for solution for the healthcare organization. We created a new portal that enabled raw data, not everything as all researchers would want to be, of course, but it is open for anyone for grabbing, because we understood that this data is supposed to be for the greater good, for the Israeli greater good, but also for the world. And everyone from this conference can go to data.gov.il and download some of the elements or regarding our COVID data. But that's not all, because what we also did was to establish a new COVID big data platform that actually encapsulated every single data from all organizations that was designed, of course, with the proper authorization, with the IRB, with the privacy issue, and etc. And the ability for researchers not to go to each organization, but to one-stop shop with very high advanced tools to create a new search and a new research platform for all of us. And the third and final thing regarding R&D is to create an intergovernmental and interagency, academic, but also the military and everyone that is dealing with technology in order to create innovation within the system. Public engagement is also important. And of course, I'm not going to, we've talked about trust, and of course, multi-channel social media and information outreach is important, but also to create different opportunities for the public to interact. We actually created with a company from Israel, an application that allowed us to interact information, but also for the public to create their own communities regarding COVID, whether it's patients, whether it's just people who wanted more information, to ask themselves, we are not the only one with knowledge regarding this. So enabling that social ability was also very important. And lastly, but not least, of course, telemedicine. Telemedicine, this is the year of telemedicine throughout the world, because as we saw, and when we came to COVID with a pretty good idea, because we had the right regulation that enabled it and some techniques and infrastructure that were allowing different telemedicine services to be incorporated within the system. But this was something else. We also saw a rapid exchange within front services and, of course, telemedicine. And we made sure that every hospital, every HMO can allow different chat, voice, video, remote devices for the patient, but also for the physicians. That was also very important to allow that transition to come in ease and to help everyone throughout the country. So that was a bit about, again, what we had before and what we had during COVID. Now let's really, in a few short seconds, let's talk about what's the new normal, because that's what we're really looking at. And when we're trying to look at the different abilities and different trends, we're understanding that we have to tackle different elements of the situation with different tools. Engagement with the public, with the physician, with the ecosystem. Not only digital, but digital alongside of analog, because there are a lot of literacy challenges that we need to face in different communities and a lot of things, to act fast and adapt, to promote new regulation and policy that is in the age of COVID, centralization sometimes, but also decentralization, to allow innovation within the system, to develop new infrastructure, and to allow acceleration that this shift that was happening regarding the usage of digital health is not something that's only going to be in the next month, 3 months or a year, but it's going to stay for long. How to take this 10-year leap in 5 months and to stick it for the entire system. And this is something that has to be done with every single point of digital health. And that is quite a lot of issues. As you can see here, this is just a very short list of things that we're currently dealing in, again, with policy, infrastructure, and incentives regarding our cloud usage and de-identification, telemedicine and AI, interoperability and privacy, and many other issues that are in the core element of our usage of our digital health understanding regarding the treatment, regarding how the healthcare system is going to manage. And really with a few final remarks for me and what we've learned during this time and how we're going to continue on treating and acknowledging digital health is that, first of all, especially when a pandemic hits, but not only, you have to act. There is no other way but to take immediate measures to prepare the healthcare system, to allow new technologies for the next pandemic, for the flu season that is now hitting us because it's winter here, and to act as fierce and as fast as you can. Then you have to learn. You have to understand what happened, to utilize every single point of data that you've got within the system, within the organization, to allow big data research, to interact with different organizations, the public, the researcher community, and a lot of other things, and then to understand how your current models are working, what are good and what are bad. Then you have to adjust. You have to transform, and it's not an easy thing, because once you're committed to something, it's not easy to change it, but you have to transform your current models of operation, adapting to challenges, in policy, in practice, and cooperation within the country, local, but also internationally, to be fast and precise in measures. And lastly, you have to act once again. You have to allow for new innovative technologies and methods to be incorporated within the system. You have to create enabling ecosystem throughout the scope within the country, but outside of it. And you have to then repeat the process, because otherwise you're just going to be left behind. And not only your organization, but your country will suffer from it. Digital health is the future. Digital health is the current, is now. And with that, no question, because we're going to go to question in a few seconds. That was my presentation. That was the Israeli experience regarding digital health.
No i to było właśnie to pytanie, że
Okay, and that was the question or the claim that we can't afford to waste the crisis. Yes, because it's a brand new opportunity, and this is what I'm going to ask our panelists who are going to comment on the Polish context, on Polish developments. Please turn on your microphones and camera and share your comment. We have about a quarter of an hour, so I'm going to ask you to answer one fundamental question. Please tell us, how do you see this fundamental change from the perspective of hospitals, payers, patients, and the IT sector? So, ladies and gentlemen, I will be asking our panelists to vivisect changes and tell us how to make the most of the time we have right now during a crisis, which hopefully will not happen too often, but they do happen from time to time. And if you know there is a crisis looming ahead, you have to be prepared to make the most of it. So how to prepare yourself for the crisis and how can we tap into it? You know, all the new, those different waves that come one after another one. I'm not convinced that it's not going to happen in the future. Well, it is an ongoing pandemic and there are new challenges underway. I'm sure that next time we should be prepared better because we have gained experience. In recent years, Bill Gates said that the main threat faced by the mankind will be probably a virus. But it was with what-ifing in the past. Right now, we know that these are genuine challenges and they can keep on coming back. Yeah, well, the pandemic is the part and parcel of today's life. We just have to be ready to face them. Well, not everything can be mitigated because very often it's a costly exercise, but we can have this mental advantage. We can make the most of the crisis to build a brave new world. As we see it. So I've mentioned this brand new trajectory we should be following. Okay, so let's go back to our panel. Right now, I would like to give the floor to our panelists. I can see you again. Professor Jarosław Fedorowski, the head of the Polish Federation of Hospitals. Please share your perspective. Okay, I understand I should be speaking Polish. Yes, it's interpreted. Okay, I'll do my best to live up to the challenge. Well, it was a pleasure to listen to those exciting presentations and having visited Israel during hospital study tour with the Polish Federation of Hospitals back several years ago. This coordinated healthcare system seems to us the target system we are aiming at. And what I liked most was proactive support. And this is something that I try to present in very different media. I often argue that this crisis poses a challenge, but it's also an opportunity to improve our IT resources, for example, or improve our data flow. So what is happening right now? We see hunger, massive hunger for reliable information. There is a dire shortage of it. So information that is fed into the system, and this need is voiced by hospitals, but also other stakeholders of the healthcare systems. For example, bed management in hospitals. Digitization and state-of-the-art systems would be very helpful. To give you a specific example, the Polish Hospital Federation Association teamed up with its partner, designed a model of digital management of hospital beds, and this system was practically up and running, was ready to be fed with data. And these are not emails, these are not tables in Excel sent by heads of hospitals or coordinators, but it's a very modern system, very similar to booking systems or airplane booking systems. So it's true that we can learn a lot, and we have learned to cooperate. Grassroots initiatives are very helpful, extremely helpful in promoting new technologies, new solutions. Another thing is you need to rationalize your resources, and we see it all around the world. For example, intensive care is a great example. The European Society of Intensive Care has been promoting its guidelines, and it is calling for optimization of resources because of the overload of the system. For example, there is another course available online which puts the spotlight on optimization of hospital beds when there is a dire shortage of them. Modern tools. An intensive care physician, for example, some of my colleagues probably will be smiling ironically, but please imagine that such systems have been put in place. For example, in the US, it's called virtual intensive care. I know it's unthinkable. How can intensive care go virtual? Is the physician virtual? Is the patient virtual? No. Those systems related to data transfer, overseeing patients and therapies, when, for example, those top-notch physicians from intensive care, they are meant to be taking decisions and not adjusting the respirator, the ventilator. So there are guidelines which will help us optimize resources, and we should be tapping into them. I know that we have little time, but I'm trying to bring you up to speed with my comments. The human factor, for example. Well, technology is meant to make our life easier. It must help us. I know it from my experience, a person who, together with others, was leading and managing the hospital through the period of transformations, and it was not in Poland. And I was on the team. So this is the opportunity we are now facing, and we have to make the most of it to complete digital transformation. For example, e-prescriptions are the best example. E-prescriptions have helped us enormously in Poland, but in such circumstances, we shouldn't be resting on our laurels. We should optimize e-prescription system even further, because there are some data that could be automated even more. There's no need for the physician to have them entered manually. So to recap, there is a whole variety of factors that come into play, but it's mainly the human factor, access to reliable information, feeding the IT system with data from reliable sources, and another thing, application of state-of-the-art technologies and overcoming fear that technology will take away our work tools. To be frank, I myself have been using ultrasound in my surgery that is connected to my smartphone. And, there's no reason to be afraid. You need to put your traditional stethoscope away in most situations, because it's not a very modern tool.
For example, our vaccines. with the latest technology. Also preparing vaccines in the future. That also involves or will involve IT tools and artificial intelligence too. Thank you very much. Thank you, Professor. So this moved us quite seamlessly into the topic of how we perceive the change, especially the doctors, how they perceive it. On to the next panelist. How would this change be utilized for improving the health system? Because you doctors are the key to the actual treatment. Thank you, ladies and gentlemen, for inviting me to the conference. It was quite with interest that I listened to the previous statements, and someone said that we're on a very spiking trajectory. Well, today we train students, people who have never touched a patient, never touched a human being. Everything that's going on now is e-learning, so they are prepared for the telemedicine the best way. For us, the transition to telemedicine or e-medicine was difficult. However, paradoxically, there are people out there for whom the contact with a patient will be the second best option and not the first choice. And I believe that through this approach, the 3 or 4 grade students, telemedicine will not remain the only one way to practice medicine, and that sooner or later they will have practice, hands-on practice. Of course, for us doctors, pandemic is a challenging time, but nobody dares to say that as the doctors who actually inhibit implementation of digital revolution. I think doctors cope with the telemedicine very well. It has become the standard, rather not. But we were quite skeptical about the mental ability of the doctors to switch and follow the spirit of the growth. Last year, that was the predominant thought at our conference. This, however, proved a great success. So we are not the inhibitors. We walk in step, spring in our step towards the future, and we persuade our students to do the same. Great success. We have 2 challenges, as the previous speaker said. The first challenge is, of course, about trust. It saddens one to say that this trust is not at a very high level. The e-consultations in Poland have become notorious. People people present the e-consultation as the only way possible nowadays, which is not true. What is missing is the actual information or where this e-consultation is situated as part of the whole system. Next thing is the trust between the patient and the therapist. We launched the eProtego application early that year, and only 3% of the patients downloaded it because of fear about what is going to happen with the data. So several times less people in Poland downloaded that application than their peers in other Western European countries did, because people had distrusted the security of the data. And this brings me on to the thing that I'm missing most, namely how to approach the failures on the path to digitization. I long to hear at such a conference like this that speakers say not only about successes, but also about failures, stumbling blocks, and how they overcame them. because we all need to switch from the mentality geared towards the success towards one that also incorporates failure as a natural part of bringing the public health system towards the digital future. And my sense, my feeling is, and I believe that I speak also on behalf of my fellow doctors, is that a political criterion is also added to the failures or successes, that communication for political reasons is geared towards demonstrating success. But if we concluded that the eProtego application is downloaded by too little people because of safety concerns, we would have made a step further, because in the next revision this application would be better. Now we have reached a very important point, namely the patients. We also concluded a very important cultural message that failure is part of the risk. If we're taking up a risk, then we have to reckon with failures. So now I give the floor to next two panelists to summarize it also from the point of view of the IT industry. Well, trust to patients. Thank you very much for giving me this opportunity to speak this very important and interesting session. Having listened to the keynote speeches and previous speakers' contributions, I would say that the healthcare system started moving towards what patients as individuals, as organizations had already covered before the pandemic. Everybody understood the strength, the power of digital transformation in something that we call patient empowerment. What is missing from the point of view of the patients as part of the transformation in our country is that we should think more about those tools, not as a digital prosthetics for the services that cannot be offered right now in the offices, in doctors' offices because of the pandemics, but also we should think about those instruments as a way to improve the relationships between the patient and the team of health providers, doctors, nurses, also going forward, so that the idea of co-responsibility for health that is promoted in Poland, that is transformed into actual patient empowerment. And this is exactly what digital transformation can do, because that allows the patients to understand better their health problems and to control it in a more efficient way. We can use various tools to monitor the health of the patient, the status of the patient, also for the doctors to improve their knowledge, and also for the patient to understand better what is going on with him here. So I believe that we have spent too little time talking about this aspect in Poland. If we want the e-consultation, teleconsultation, that has become notorious on the one hand, it saved the general practitioners' business, because it's actually the on-ramp bridge for consultations, and on the other, it became this scapegoat as people discover that new standards are required which are not there, and we need to fix the actually procedures where e-consultation is okay and when it is not. So we need to move on from thinking about those e-consultation in a traditional way towards making the digital transformation a way for enabling the patients to exercise care for themselves using the tools and for them to communicate with doctors better. And I think that lesson that Dr. Jankowski say about this application ePro2Go was about trust. And I believe the level of trust is low, as the pandemic surveys at the very beginning showed. Also, there is little trust to the information on the pandemics provided by the media and by the government. So this is a definite problem of trust, not only to the medical professions, but also to public institutions at large. When we speak about digital transformation and sharing data, it will be very, very difficult to roll out advanced tools without that trust. And also the issue with the application demonstrated quite clearly that it is the people who need to understand in the first place why they need that application. So I believe that a communication mistake was made, because this application has never been advertised as something that helps you. People understood it rather as something imposed from the top to control me, to control myself. So it was not quite well understood. So the key to the digital transformation's success will be to plan it and to roll it out in a way that is safe, secure, and well communicated as something which is safe for the patients, so that the digital value added would be added for all, enabling the transformation of the public healthcare towards more efficient, safer, and more effective collaboration between the patient and the medical team. Thank you, Maria. And I think pointing out to this trust context is very important when we consider launching technologies that transform our behaviors, our lives, our ways, how we contact with how we interact with other people. Now on to Krzysztof Gronicki of ASECO Poland. The question is, how does the IT sector perceive this watershed point, and how we can use the assistance of the IT as patients and the general public at large to move towards something that will be more acceptable? I relate thereby also to the issue of trust, because we speak about new ways how businesses operate and interact. I know that we have actually went past our time window, but I hope that we will make up for the time that was otherwise not lost, but overrun. Okay, I will skip the optimism because of the time passing by about how great it was to implement the e-prescription and e-reports. I think we are now in the process of implementing the so-called EDM system, with the first medical event entered yesterday in the system. Now, let me comment on a somewhat different note. The previous speaker spoke about this digital transformation curve. I'd love to know where we are on this curve, because I'm afraid we are still on the dropping end, and I want to believe that we're going to rebound and go skyrocket to the unexpected heights. But in order to move towards this rising part of the curve, we need to shed the old mentality in old institutions and embark on new instruments. In addition to implementing those rather simple tools such as e-consultations or e-prescription, and the previous speaker spoke why the e-consultations have such a bad press now. Charles also spoke about how this e-consultation differs from the actual physical contact with a physician. This is not going to be overcome easily. So there are certain things that we need to do before we rebound. First, we need to take stock of what we didn't know. Our Israeli guest said that in the old normal, we have not built up the institutions that would be the actual decision makers in the times of pandemic. For example, we have just discovered that the test results are not correctly reported, because commercial tests were never reported on the same way. Also, in various hospitals, there are different reporting standards, the IT system with different reporting standards. And the actual number of tests and the difference from the real values actually dramatically undermined the trust to the public authorities. One person called 3 decision makers, and overnight an interface was established which made the commercial testing and also public testing being reported in the very same way. So from now on we have, at least theoretically, a single information channel. This should have been done earlier on. Why was that not done? This is because we built barriers between the public medical system and the private medical system. In the old normal, that silo structure gave the public sector a certain comfort. For example, the public procurement situation was easy and comfortable. However, when the artillery barrage started, we had to bring down those walls, contact each other, and that led to the way that you can actually agree on certain standard overnight. So we should relinquish those old institutions and create a fast-track consultation method that will be able to implement IT. Of course, IT systems are still they still do contain a lot of errors because the statistical data has not been captured in a proper way, and they're just sort of roaming the system, and are now, let's say, by fluke discovered, dug out by teenagers or by various institutions that are not meant to do that. So far for pessimism, however. On the more optimistic note, I'd say that optimism can rely on the ability that we can quickly communicate and actually improve our communication channels. So I do hope that the conclusions that we can draw from it, lessons learned, would bring us to actually rescinding the old normal and implement institution that will allow the fast track of decision making.
And the same goes for cooperation of the private and the public sector, which decision was taken quite a right. But to cut the long story short, in times of pandemic, we definitely need central management. We need swift decision making, but you can't centrally manage anything without the right tools, without systems ensuring flow of information. And now reasons to be fully optimistic. The pandemic did not stop IT implementations in hospitals from March until today. My company has implemented in 20 hospitals systems from the scratch. We have migrated systems and data. In more than a dozen hospitals, we have implemented patients' portals, e-consultation systems, so patients get information faster than the physicians. So the pandemic did not stop us in our tracks. We are on the right track to improve the system. Why? Because no one is asking anymore, is it worth it? How to do it? Perhaps we should wait. So we are now talking how fast, what changes, and how will it be done. No one is giving it a second thought. You know, we're thinking mainly about how. So hopefully when we meet next year, we'll be able to say that we have learned our lessons from the pandemic and we have embarked on the track towards exponential growth. Thank you very much for this optimistic note, because it's time to see the sun after the rain. So thank you very much for highlighting this institutional aspect of change, because we need to build a robust institutional order. Okay, we are really running late, but thank you very much for this discussion, which was very much needed. I think we should be discussing fundamentals of the change, not only reflections of change, more often in order to react swiftly and effectively to developments as they unfold and to learn our lessons for the future. So, ladies and gentlemen, I apologize, we can't continue our discussion. I would like to thank our panelists for sharing their insights, for excellent presentations, and all the best to you, and hopefully see you next time in person.